Good evening and welcome to the Center for Biomedical Ethics Global Ethics Lecture. My name is Chong Yap Singh. I'm the Dean of the Yong Loo Lin School of Medicine at the National University of Singapore. So I'm sure you all know who you are coming here tonight to listen to, so I'll make this very brief. So Professor Peter Singer has been described as the world's most influential philosopher. Educated in Melbourne and Oxford, he has been professor of bioethics at Princeton University since 1999. His many books include Animal Liberation, often credited with triggering the modern animal rights movement. Practical Ethics, The Life You Can Save, The Most Good You Can Do, and Ethics in the Real World. Some of his other very well-read books. In 2023, he published Animal Liberation Now, a fully revised and updated version of the 1975 original. So Peter's writings have also inspired a movement known as effective altruism, and he's the founder of the charity The Life You Can Save. In 2021, he was awarded the US $1 million Berggruen Prize for Philosophy and Culture, which he donated to non-profit organizations working for the causes he supports. In 2023, he received the 15th edition Frontiers of Knowledge Award for Humanities and Social Sciences from the Spanish BBVA Foundation. So it's a really great privilege for us to have him here tonight in Singapore. He will speak on pandemic ethics, 5 lessons. I promised I wouldn't give away what he was going to talk about tonight, but essentially he will discuss allocation of scarce resources, challenge trials using human participants, mandatory vaccinations, lockdowns, and managing pandemics. Professor Peter Singer, please.
Thank you very much. Thank you. Thank you very much for that introduction. I want to thank Julian Savulescu and others from the Center for Biomedical Ethics for the invitation to be here. And of course, I want to thank all of you for turning up and providing an audience. Although the pandemic we may think is past, not entirely perhaps, I see a number of masks in the room, but I think we can be fairly confident, regrettably, that this will not be the last pandemic. And even if it were, I think some of the lessons that we learned from the pandemic are relevant to everyday decisions that we still make even in non-pandemic circumstances. So I thought it would be interesting to discuss some of those lessons and to put them forward as suggestions, stating my own views on these matters, and I know that we have plenty of time for questions and discussion afterwards, so no doubt there will be some of you who disagree with suggestions that I'm making, and I'm looking forward to hear your comments when that time comes. Right, so let's start with, assuming that works, yes. Let's start with the first lesson, which relates to the situation with regard to intensive care units and the change that occurred in some countries anyway when the pandemic struck. So before the pandemic, the accepted rule for allocating beds in an ICU was this one: first in, first served. If you were in the ICU, you stayed there. If that meant that ICU beds were full, then, and there was somebody else who would benefit from admittance to the ICU, they could not be admitted. Now, generally speaking, outside the pandemic, I think most developed countries, certainly this would be true of Australia, the United States generally, and no doubt here, would say, well, we have sufficient ICU beds. Even if our ICU is full, there is another ICU somewhere that we could transport patients to. So this isn't a realistic problem. And in fact, when I was at Monash University before I went to Princeton, so I'm talking about the 1980s and 1990s, we used to run intensive bioethics courses for healthcare professionals. I think Julian would remember those, where we had to make up scenarios for why the ICU was full and invite healthcare professionals to decide who they would admit. So, for example, we talked about a country hospital, some long distance from other ICUs, and a bus that had crashed nearby, injuring many of the passengers so that they needed ICU attention to survive, but there were more of them than there were ICU beds. However, when the pandemic struck, that hypothesis, that fictional story, became a reality in many places. Particularly, I think one place where it clearly was beds had to be allocated was in Italy, the first country outside China to have a major outbreak of COVID-19. And you may remember photographs of beds being set up in the parking lots outside hospitals because the hospitals were overflowing with patients. So in that context, decisions were being made and the first in, first served rule was jettisoned in favor of a different rule, which was essentially to maximize the benefits to be achieved by ICU admission. This was formalized by the Italian Society of ICU people and anesthesiologists and others who actually put this in guidelines, somewhat controversially, and the guidelines were then reviewed by a national bioethics committee sometime later, which disagreed with them, but by that time the first wave of the pandemic had passed and the allocation of beds during that first wave was in accordance with this idea, which essentially meant that you admit and continue to treat only those who have the greatest chance of survival and are likely to have the most years of life ahead of them. I should say greatest chance of survival if admitted to the pandemic, but a very low chance only if not admitted. So essentially, that was to maximize the benefit of admission in terms of number of life years that could be expected to be saved by admitting patient A rather than patient B. So that tended to mean that in terms of life years anyway, if the expectation of the need to be admitted to survive was the same, you would admit younger patients rather than older patients, because the younger patients obviously would expect to survive, to live for longer if they did survive the pandemic itself. So, so that led to some objections. This is a quote that appeared in The Guardian when similar things were being discussed in the United Kingdom. And it was objected that rationing care based on age was, quote, a dangerous knee-jerk ageism where the older we get, the less value we have and the less important our lives are to save. Now that was said by Catherine Foote on behalf of the Centre for Aging Better, so she was somebody who was working with aging patients. But I think it's worth looking at what is being said here. It sounds like a serious criticism that this is denying value to older people, and that this is ageism, a prejudice, that term suggests, like racism or sexism. But if you look at what is being said, I think you have to ask whether this is indeed an incorrect position to take, that the older we get, the less value we have and the less important our lives are to save. Now, I can say that I am not here arguing from my own interests, because I'm a good deal older than most of you in the audience. But I do think that if there were a choice between saving my life and the life of somebody 20, 30, 40, 50 years younger than me, then I do think that, at least other things being equal in terms of the prospects of saving the lives, I do think that it's less important to save me, whatever my life expectancy might be, and we don't know, but it's quite unlikely to be more than 20 years, let's say, whereas for younger people, it's very likely to be significantly more than 20 years. So when you look at this quote, bad as it sounds, you have to ask, is this really a prejudice, or is this actually making sense? That to give people more years of life is more important than to give somebody only a few years of life. And that even puts aside the question of the quality of life, which again, we might think, not unreasonably, starts to decline at a certain age. That age is not the age I've yet reached, I can tell you, but no doubt it will happen. So I think that I don't regard this as a prejudice. I think it's something that we ought to accept, that the older we get, the less important our lives are to save. Again, other things being equal. Okay, a somewhat more plausible objection, I think, to the idea of maximizing benefits, in other words, to the straightforward utilitarian view, is what is known as prioritarianism among philosophers. It's a view that says that we should give priority to those who are worse off. And this is something that does have a kind of popular appeal. We think that generally governments ought to do more in terms of policy for those who are worse off than for those who are better off. Now, sometimes that might still be compatible with a straightforward utilitarian view, because we might be saying that because actually governments can do more for people who are worse off than they can do for people who are well off. That is, people who are really living in poverty, lacking basic necessities like sufficient food, shelter. You can more easily benefit them through changes in government policies that assist them than you can benefit people who are already well off. And that perhaps is part of the phenomenon that says it's easier to make an improvement in someone's welfare when they're really in a bad state, and you can lift them up into a at least neutral state, than it is to improve the situation of somebody who's already well off. Because it's quite hard to know how to make somebody who is meeting all of their basic needs to make them happier rather than just leave them as they are. So it's not clear to me that the common intuition that we have to favour giving priority to those who are worse off is actually prioritarianism as philosophers understand it. That is, it's not necessarily saying that we discount improvements in well-being for those who are worse off and favour similar quantities of improvement for those who are worse off over those who are better off. But there are philosophers, including Derek Parfit, one of the philosophers that I was fortunate to get to know when I was at Oxford and subsequently, and one of the philosophers I most greatly admire, who had some sympathy for a prioritarian view. What I want to do in this slide, though, is to get you to think about what exactly that involves and whether indeed we should give priority to those who are worse off. And here, because I'm talking about pandemic situations, I'm just considering worse off not in economic terms, but in terms of how likely somebody is to die, and given the age at which they are. If, again, we assume that we're in the pandemic, they have a serious case of COVID, they need an ICU bed, but one of them is age 30 and one of them is age 60. And if you don't know anything else about them and about their lives, it's reasonable to say the person who is likely to die at age 30 is worse off than the person who's likely to die at age 60, because they will have had less time to live, simply. They will have had fewer life years. So that is, I think, a reasonable way to think of this, other things being equal. But how much weight do we give that? How much weight do we give the fact that somebody is worse off in terms of they will die younger without the ICU bed, as compared with how much difference, how many extra life years we may be able to give them if we do treat them? So that's why this is, again, a hypothetical case here, just to try to get you, as a thought experiment, to consider your views on this. If the person aged 30, even if treated, will still only live 10 years, whereas the person aged 60, if treated, is likely to live 20 years, does the doubling of the years, the 20 versus 10 years, does that outweigh the fact that they are better off because they've already lived 60 years? Or does it, or is the fact that the younger person is worse off in terms of likely to being able to die, likely to die younger, does that mean that they should still get priority even though they will only live for half as much longer? You'll only add half as many years, 10 rather than 20. And you could say, well, how exactly should we calculate this? So should we calculate it in terms of years, just absolute time to be lived? Or should we consider it proportionally? So if you look at it here, in fact, the proportions that it will add to the patient's lives are equal. In both A and B, you will add a third of what they have now lived to their life if you treat them. Is that relevant? Is it relevant that they will live a third longer, and therefore you could say, well, really, in a sense, we're giving them equal benefits, and so therefore we should give the benefit to the one who is worse off? Or is the fact that actually there are more years, and let's assume that they will be positive years for the 60-year-old? So I think prioritarianism raises a lot of interesting questions here, and perhaps in discussion you can tell me what you think about this and about this case. But it relies very heavily on intuitions. People have different intuitions when you put to them a case like this. In fact, let's just test it on the basis of what you say. I'm interested to see where you stand. So raise your hand if in these circumstances you would give the ICU bed to patient A rather than patient B. Okay, reasonable number of hands, but I would say probably not half, but maybe many of you are going to abstain. Raise your hands if you would give the bed to patient B. Well, that side is more likely to give it to patient B. This side favours A. Not sure what that shows. Okay, so well, you had reasonable numbers for both sides. I didn't count, but I didn't see a clear majority there. Okay, save your thoughts if you have them on that for the Q&A. So those are issues with resource allocation. As you can see, I think that either utilitarianism or prioritarianism ought to be what we do. I don't think that we should be simply staying with the first in, first served, and you stay in, even if it's clear that there are other patients who need the bed or have better prospects of survival or are likely to live longer with the bed than those in. Now that's going to be very difficult. I know that some of you are healthcare professionals here, some of you maybe deal with these sort of situations, others have the luxury of being philosophers who don't have to actually be hands-on, but can talk about and think about these questions. So you may have different views. And I know that for the healthcare professionals, for the directors of ICUs and those working there, it's very difficult to say to a patient, I'm sorry, but we have somebody who needs the ICU bed more than you do, and so we're going to shift you out to an ordinary hospital ward, where of course we'll do our best for you, but you won't have the resources of the ICU. That's a difficult thing to do, and maybe that's why a lot of healthcare professionals say, no, I'm going to stick with first in, first served. But I think situations like the pandemic force us to reconsider that rule, because sometimes at least the benefits are so clearly greater in terms of a patient that you can't admit that you don't want to stay with the first in, first served rule. All right, let's move on to the second of these lessons, which, sorry, I went backwards then, didn't I? Which is the use of human challenge trials in research. Now, this was relevant during the pandemic in terms of developing vaccines for the pandemic. It's against the background of this general principle, which here is stated by the World Medical Association's Declaration of Helsinki, a well-known Declaration of Medical Ethics, dating from 2013, but going back some time, going back, in fact, I guess, to the post-Second World War era, when there was such horror at the revelations of the experiments performed by doctors, medically trained people, on concentration camp prisoners. So there was an insistence, it says, that medical research can never take precedence over the rights and interests of individual research subjects. And we might still think that that is the right stance, particularly if we are talking about taking precedence over their rights, and if we have a clear view of what those rights are. Of course, we don't always have such a clear view of what those rights are, but generally in the case of research on human subjects, it's regarded as requiring the informed consent of the patient, or of the research subject, I should say, or of the parent or guardian if we're talking about research involving children. And we might see those as basic rights. Interests is a little more vague, and how great do the interests have to be, and what are those interests? So I want to suggest that during the pandemic, and perhaps in other circumstances, it was appropriate to apply a different standard, and that standard is the principle of risk parity. So by risk parity, as I explain here, I mean that if in a certain situation risks were being imposed on some people in the community, perhaps healthcare professionals, such as health workers during the pandemic, who were required to continue working because if they didn't, then nobody would be getting treated. But the fact that they were working in wards with patients infected with COVID obviously exposed them to risk. And I'm talking here of the time before there was a vaccine. So the risk was quite high, less for younger people than older people, but still significant. So if we felt that it was necessary to require healthcare workers to continue to work during the pandemic, then we were exposing them to a certain level of risk. So the principle of risk parity says if that's acceptable, if that's necessary, then it's permissible also to expose fully informed volunteers to a comparable level of risk in the context of promising research into the virus, or specifically into the development of a vaccine against the virus. So where are these fully informed volunteers for research into vaccines for the virus? Well, in fact, there were plenty of them. There was an organization set up as part of the effective altruism movement. Some people involved in effective altruism organized an organization which they called One Day Sooner. The idea of the name One Day Sooner was that every day at that stage, worldwide, thousands of people were dying from COVID. And so every day sooner that an effective vaccine was developed and produced was going to save thousands of lives. And therefore, it was really important to think, how can we get a vaccine in the fastest possible time? So quite a substantial number of people. This is the current total. I checked the website a couple of days ago. Currently, over 43,000, nearly 44,000 people are volunteering to take part in human challenge trials. This is, interestingly, at a time when we actually have effective vaccines, but there is still other work that can be done using human challenge trials, particularly testing efficacy of new vaccines on, or modified vaccines on variants. And we're now talking about, certainly the United States, research is going on in producing vaccines that will be better for the new variants that are developing at the moment. At the height of the pandemic, before there was a vaccine, there was almost this kind of number, something like 35,000 volunteers were on the website. They were generally younger people who in any case were at less risk of dying from COVID, and they were well informed about the risks that they were running. The idea was simply that if there were promising candidates for vaccines, then the human challenge trial would involve, firstly, vaccinating volunteers with that, vaccinating them with the promising candidate, or with a number of, perhaps dividing them up into randomized groups and vaccinating them with different candidates, and having a control group unvaccinated, and then deliberately infecting them with COVID. So had that been done prior to there being any vaccine, I think it's reasonable to believe that that would have enabled us to determine more rapidly which was likely to be the best candidate vaccine. It was not done because of reservations about using volunteers in this way. There was a debate. Some people were opposed to it. And in fact, the offers to take part in human challenge trials were not taken up until sometime after vaccines were available. So there have been a relatively small number of human challenge trials drawing on these volunteers, and I think they have had some effect, but they didn't have the very large effect that those who set up One Day Sooner hoped that they might have. Ethically, I think that that was a mistake, and these are the conclusions that I would come to. This is simply applying what I've been saying, that if each day that delays the availability of a safe and effective vaccine costs thousands of lives, if, as was the case, healthcare workers are required to work in conditions that expose them to the virus, and if healthy and informed volunteers are available, then human challenge trials are ethically acceptable. And I hope that this principle is increasingly recognized, especially in situations if we get either new variants or completely different pandemics, that we won't make the same mistake next time that I believe was made this time, and allow many thousands more people to die because we didn't get a vaccine as quickly as we might have. All right, moving on to the third lesson, which is relating to vaccine distribution. Again, there was a lot of discussion when vaccines first came out and were in limited supply as to who should get them. This was a discussion, this graphic is taken from the New York Times, an article about whom we should save first with the new vaccine. The article was in fact based on a discussion panel in which I participated. And again, I would say the best allocation is how they will do the most good. What distribution will do the most good? And in fact, that, I think, in the COVID situation had two clear consequences. First, whoops, I've gone backwards again. Firstly, the healthcare workers who I mentioned before should be getting priority because they are at risk. They're not even really volunteers. They are people who had a job which seemed reasonably safe before the pandemic came along, and then the pandemic came along and many of them were getting ill, some of them were getting seriously ill, and they were doing their job. So they're also necessary. A lot of ICUs were short-staffed because many of the healthcare workers were getting ill from COVID and having to be away for periods to recover. So that's a high priority. Benefits to the healthcare workers, benefits to the patients. I think it was right to give them the vaccine first. But secondly, the elderly were much more at risk of dying from COVID than the young. So even though, as I said earlier, talking about the allocation of ICU beds before there was a vaccine, even though they were likely to have fewer life years that admission to ICU could save, if in fact they're much less likely to, if in fact the elderly are much more likely to die, a much greater risk of dying than the young, then when a vaccine became available, I think it was right to distribute it, to give priority to the elderly there, as was generally done, to reduce the number of people who would die from the virus. However, there was a complication that was discussed particularly in the United States, and that was due to the fact that if in fact you select elderly people, particularly if you start at a fairly high level, let's say you say, well, we don't have very many doses of the vaccine available, we're going to give them to people who are 80 and over, because they're the ones who have the highest risk of dying. That's reasonable, but some people pointed out that that actually would mean that disproportionately few black people got the vaccine. Why? Simply because the life expectancy of white people in the United States is significantly higher than the life expectancy of black people. And there are various reasons for that. Obviously, poverty is something that affects life expectancy, and there are more black people living in poverty than white people. Educational level achieved affects life expectancy, and again, that counts in favor of white people. And perhaps even black people are disproportionately victims of crime, and that may have a small effect as well. But it was probably mostly those general health issues that are probably related to socioeconomic status. So, is that a reason against simply taking age as the primary criteria? And I argued that it was not. Some people thought that you shouldn't be giving disproportionately more vaccines to white people. I argued that it was not because, in fact, focusing on those who were older were actually going to save not only more lives of white people, but was going to save more lives of black people too. Because the difference in their likelihood of dying of older people was so great that it would outweigh the fact that there were actually somewhat fewer black people in those higher age categories. But I think, in fact, what we should be focusing on here is simply benefit. again, the benefit to the people who are going to get the vaccine. And if there are, you could have other categories with particular underlying health conditions who are more at risk as well. It wouldn't have to be only age. But I don't think we should be so sensitive to racial differences that we're actually going to reduce the overall benefits for the population because someone points out, hey, there's something unfair going on. More white people are getting the vaccine than black people, even when we take into account the proportion of white and black people in the population. A similar question can be asked about international allocation. And here I think we don't have anything to be very proud of in what happened and what to some extent is still happening. That is, we have not maximized the number of life years saved worldwide through a global distribution of vaccines. On the contrary, we're over 70% of the world's population now having received at least one dose of the COVID-19 vaccine. But in many low-income countries, countries in sub-Saharan Africa in particular, the majority of people have not received even one dose. If you look at the figures, it's in some countries it's still only in around 30% or 40%. So there's still a great disproportion. Now, you could argue that this is still compatible with maximizing benefit because age distributions in poorer countries, again, you could look particularly at sub-Saharan Africa, age distributions are very different from those in developed countries. So much higher proportion because population is growing much faster in Africa than in, say, in European countries or in Japan, even in China. So you could say, well, younger people are at less risk of getting COVID, so it's reasonable to say that there would be fewer allocations of vaccines to people who are at less risk. But I think by now we have got to a stage where in fact everybody, at least everybody who's willing to get vaccinated, and of course there are some dissenters in many countries who are not willing to get vaccinated, but everybody who's willing to get vaccinated has had the opportunity to get at least one dose, and in many countries 2, 3, or 4 doses of the vaccine. So I do think that we should be still making greater efforts to make sure that people in low-income countries who are willing to get the vaccine and would benefit from it can receive it. Now, apart from allocating the vaccine, another ethical question that was discussed during the pandemic is, should we mandate the vaccine? Should we in some way require people to get vaccinated? And that might be actually by requiring it by law, so fining people or even possibly imprisoning people who refuse to get vaccinated. But the mandates that were discussed were generally not as severe as that, but they were restricting opportunities of various kinds to people who were not vaccinated. So it might be that the workplace said, you can't work here if you haven't been vaccinated. Universities, Princeton had a policy which was not quite this, but it did say that you had to be vaccinated or else you had to go and talk to somebody and explain why you were not being vaccinated, whether you had a serious reason, a religious reason perhaps for not being vaccinated, then you could get an exemption, but it was made difficult for people not to be vaccinated. And some places, using public transport, you had to be vaccinated. So for many people, even if their workplace didn't require it, they weren't going to be able to get to work, or maybe not even able to go shopping if they were not vaccinated. And some stores, if supermarkets require vaccination, then again, it's more or less mandatory. So, is that justified? And one question is it justified for paternalistic reasons? So this is the kind of slide that people who give you training in using slides say, never do a slide like this. There's just too much to read on it. But, and those at the back, unless your eyes are really good, you probably can't read it. But I'll read it for those who can't. And I think it's quite a moving quote, which is why I have put this up. So this is a quote from a doctor, Dr. Brittany Kobier, who was working in Birmingham, Alabama, in a region where there were quite a few people who were saying, this is early after vaccines came out, who were still saying either COVID is a hoax or COVID isn't really that serious, whatever it might be, and we're not getting vaccinated. So she wrote, or she posted on Facebook, I'm admitting young healthy people to the hospital with very serious COVID infections. One of the last things they do before they're intubated is beg me for the vaccine. I hold their hand and tell them that I'm sorry, but it's too late. A few days later, when I call time of death, I hug their family members and I tell them the best way to honour their loved one is to go get vaccinated and encourage everyone they know to do the same. They cry and they tell me they didn't know. They thought it was a hoax. They thought it was political. They thought because they had a certain blood type or a certain skin colour, they wouldn't get as sick. They thought it was just the flu, but they were wrong. And they wish they could go back, but they can't. So I think it would be reasonable to suggest that in those circumstances, if you have a large proportion of the population like that, they are misinformed, and it's a kind of what's sometimes called soft paternalism to say, no, you have to have it because your refusal of the vaccine is based on false belief. And I think that is an argument that could be made. Now, of course, there's a famous objection to paternalism that comes from John Stuart Mill. Mill, in his famous essay on liberty, argued that his own good, either physical or moral, is not a sufficient warrant. This is for the state to coerce somebody. He cannot rightfully be compelled to do or forbear because it will be better for him to do so, because it will make him happier, because in the opinions of others to do so would be wise or even right. Well, Mill did, however, make a kind of exception to paternalism, not entirely so. He said that if somebody is about to cross a bridge and you know that the bridge is unsafe, you can stop him from crossing the bridge until you've informed him that the bridge is unsafe. But that's all you can do. If, knowing that the bridge is unsafe, he persists in wanting to cross it, then he's the best judge of his own interests, that is, of how much he needs to get to the other side and of how grave the risk might be. So I guess on Mill's view, you could at least force anybody who didn't want to get the vaccine to go through an education session in which you present to them the evidence for why COVID is not like the flu, why the vaccine will protect them against it, why it's not a hoax, and all of those other things. So Mill would have accepted that, but he would not have accepted that if they still say, I don't want the vaccine, you can in some way require them to get it. Now, I'm not sure that I agree with Mill here. I was talking to some people from the philosophy department just before, and I mentioned that Professor Chin-Lu Ten, who was in the philosophy department here for many years, was also at Monash University when I was there, and wrote an excellent book on Mill's On Liberty. And we disagreed about the legitimacy of paternalism in some situations. And I'm sorry that he's not here to discuss that with me today, but he's now retired. So this is one of the examples where we disagreed. I believe that legislation requiring seatbelts to be worn in cars is justifiable. And in fact, I think that is a widely shared opinion now. But Chin Lu Ten did not agree with that. He again would have thought that yes, you can educate people about why they're much better off wearing a seatbelt, but if they still say they don't want to, you're not justified in fining them for not wearing it. To me, the legislation here is kind of a counter to just people's laziness or bad habits. It's not that many people make a seriously thought out decision not to wear a seatbelt. Without legislation, they just don't bother to put it on because the risk of something happening to them is low for any given journey, for any single journey that they make. The risk is obviously very low. But if you've seen people, I'm old enough to remember the days when seatbelts were not compulsory. In fact, one of my friends from university, when I was an undergraduate, was a passenger in a car that had a collision. She was not killed, but she went into the windscreen shattered. Windscreens were not made of the same type of glass as they are now. She had a horrendously cut face, which was scarred for many years. And if she'd been wearing a seatbelt, absolutely nothing would have happened to her. It wasn't that serious a collision. So I think that it is justified. But I also think in the case of mandates about getting vaccinated, there's a non-paternalistic principle that could be appealed to and that actually fits with the other half of Mill's views about paternalism, what he calls the harm principle, where he accepts that the state can legitimately exercise power over any member of a civilized community against his will to prevent harm to others. Now, not being vaccinated in a time of COVID, I think, does harm others in two different ways. One, which may be now contested, was certainly believed when the vaccines first came out, but I've seen some people contesting it, and I'm not expert on the evidence here. It seems that vaccination, or it was thought that vaccination would reduce the risk of becoming infected and spreading the virus to others. And there, I think on the balance of evidence, that is still probably the case, but there may be people in the audience who are more expert on this than I am, and it's not absolutely clear-cut that the vaccination does prevent you spreading the virus. What it clearly does do is reduce the symptoms of having the virus. And that leads to the second point, that if you don't get vaccinated, you're at a higher risk of requiring admission to an ICU. And again, we get back then to that question of allocation of the scarce resource of ICU beds. And this again happened in the United States even after the vaccine was there, because there were some areas where people in large numbers were refusing to get vaccinated. So again, there was a case that was well documented of I think it was a hospital in Western Michigan, if I remember rightly, a rural area where many people were unvaccinated and the ICUs were filling up, and the directors of the ICU were trying to get patients moved to other ICUs in the state, but they were full too. And in one particular case, there was a patient who had been admitted to a country hospital that had no ICU, but his condition deteriorated and he urgently needed to be shifted to an ICU. But because the ICUs in the region were full because of unvaccinated patients with COVID, he could not get admitted. And after trying to get him admitted for over a week, his condition deteriorated further and he died. So sadly, he was very likely to have been somebody who would have lived if those patients had been vaccinated, because they, or many of them, would then not have had such serious symptoms that they required admission to the ICU. So I think that the mandates can be justified even for these non-paternalistic reasons. Okay, just two more lessons, but I'll be a little quicker with them. Firstly, the questions of the lockdowns. Were the lockdowns justified? Something that's being debated now. I was in Melbourne during the pandemic, which I think held the world record for the number of days of complete lockdown, anywhere we had. We had 210 days in which we had really strict lockdowns. We were only one person per household was allowed to leave and only to provide essential shopping. Otherwise, we were not allowed to leave at all. We were not allowed to travel more than, even that person could not go more than 5 kilometres from their home unless they couldn't meet those essential shopping needs within 5 kilometres. And schools were closed, a lot of other things obviously closed down. So was this justified? People are now looking at the figures, comparing places that had lockdowns, comparing places that didn't. Sweden is an example of a country that didn't have severe lockdowns. Its statistics were significantly worse at first than comparable countries like Denmark and Norway. Over the longer haul, that difference diminished, although I think Sweden still had more fatalities per capita than Norway and Denmark. But there were other costs. Whoops, I've done that again. So what is the cost for children's education? Children lost more or less a year of education in school. Maybe they had lessons at home over Zoom. Maybe their parents tried to give them something. But there's certainly a cost to that. There was unemployment because of this. People were not going into work. In fact, some people say people are still not going into work, and central business districts in a number of places have still not fully recovered in terms of the occupancy of office space. Domestic violence statistics increased with people at home. There was more mental health issues. So what are the costs and benefits? Well, as the apple and orange illustration here indicates, it's really hard to answer that question. I think what we need is better ways of comparing harms and benefits of a whole variety of different kinds, which is going to be really difficult to do. I think we need more measures of subjective well-being, that is, getting people to evaluate their states of well-being at particular times. The debates about how best to measure that, whether we can do it by asking people questions, what kind of questions we ask. And we need ethical deliberation too about what factors should we only count subjective well-being as hedonistic utilitarians, of which I'm one, would say, or are there other factors that we ought to be weighing as well as that? So I think we need to do more research on that. I advocate research into well-being. I think more governments should get onto this idea of assessing the well-being of their population rather than assessing things like economic growth. But we need to do more work. We can't really answer these questions at this stage. And then, very briefly, what about preventing future pandemics? Well, there are a lot of suggestions. I certainly think we should be better prepared for doing that in a whole variety of ways, studying the risks of pandemic. But I want to mention one thing that I think is very, very simple and has other benefits, and certainly links into some of my other interests, as was mentioned in introduction, my interests in animal protection of animals and the work that I've done about that with the book Animal Liberation Now. So the fact is that pandemics, majority of pandemics come from non-human animals. And it's probably true of COVID-19. There are debates about whether it came out of the Wuhan wet market, out of pangolins or bats, or whether it came out of the Wuhan lab that was researching this. But even so, it probably came from animals that they were using for their research. So that seems to be one. The previous pandemic before COVID-19 was the swine flu pandemic, which didn't kill nearly as many people as COVID, but clearly came out of pig farms. We are now at risk of mutations of avian influenza, which also obviously comes from birds. So this is a problem that human interactions with animals is leading to. And there's one form of human interaction with animals which is bad for animals. Sorry, did I give you that? Bad for animals, bad for humans, and increases pandemics. And that's factory farming. So if you put, as you see here, maybe 20,000 chickens in a single shed, extremely crowded, they're under stress. They're stressed because chickens are not, naturally able to live well in those kinds of environments. Chickens in a flock that is suited to their nature, there may be 20, 30, 40 birds in that flock, and every chicken will know which birds are dominant over it and which birds it's dominant over. That's where we get the expression pecking order from. Which birds will peck that chicken, which birds can that chicken peck at and drive them away from food, for example. But 20,000 birds in a shed, chickens have no hope of knowing who all those chickens are. So they're stressed. In those circumstances, viruses can very rapidly spread and mutate through a large number of birds. And then every now and again, workers have to go into the sheds and pull out the dead birds, or when the birds are ready for market, catch them, usually handle them, and put them on trucks to take them to slaughter. So you're going to get viruses spreading to humans. And there have already been a few cases of avian flu spreading to humans. So far, it hasn't mutated to one that is highly contagious to humans, but that's certainly possible. And I also mentioned swine flu. Sorry. This is actually a pig farm in China. As you can see the number of pigs, these are the breeding sows in the pig farm, individually stalled. It just recedes into the distance. You have no idea how many rows there are in that shed. But similarly, as I say, swine flu came out of pig farms like this. So I think we ought to be thinking seriously about the risks that these kinds of farms pose to us. And obviously, they produce cheaper meat, that's why they exist, but do we really need them? All right, that concludes what I want to say. I just want to thank a few people because I first wrote about some of these issues during the pandemic in opinion pieces for popular media, sometimes co-authored. So I want to thank these authors, Paola Cavalieri, Michael Plant, Richard Yetta-Chappell, Isaac Martinez. And I gave an earlier version to the Hong Kong Center for Bioethics, and Alexandra Ehler was a respondent, and he got me to think more about prioritarianism in particular. So thank you very much for your attention. I look forward to your questions and comments.